The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, how to handle novel ideas.
How safe is this procedure? I mean, is it safe? Does it really work?
That's Professor Gavin Frost, former Dean of Medicine at the University of Notre Dame, Australia, who has also performed roles such as Chief Medical Officer at MBF and CEO of the Royal North Shore Hospital. And I'm presenting him with a difficult scenario.
This is a big deal. This is not something your average hospital has ever done.
In this episode, Gavin will explore how he'd work with a medical maverick. In our scenario today, a clinical manager is approached by an enthusiastic young surgeon who has recently completed their overseas fellowship. The surgeon brought back knowledge of a new technique for the management of pediatric diabetes. This novel idea involves the implantation of tissue grafts. I started by asking Gavin what would immediately come to mind as the young surgeon comes into his office all bright-eyed and bushy-tailed, saying he wanted to make a difference to the delivery of diabetes services.
Without advancements in healthcare, we'd still be using alcohol to anaesthetise people for their amputations. So we have to move forward. There's no question about that. And this guy's come to see me at a weak spot, I guess, in the sense that I have an 8-year-old grandson with type 1 diabetes. So, progress in this area is really important. And the last thing I want to do is to discourage this fellow from what could well be a major advancement. On the other hand, here we have a keen young surgeon with, as you say, wonderful ideas and not really any idea of how you have to go about implementing change in the health system, particularly involving surgery, as this does in this case. The questions that flash in my mind are, how safe is this procedure? I mean, he said it's wonderful and that's great, but is it safe? Does it really work? And behind all that is this interesting thought I've had that probably there is at least one major international biophysical chemistry company behind this. So we need to think about, the dollars that are going to be involved one way or the other. Not for us so much, although that'll come later, but, certainly it's an issue. How do we know this really works? He says it's wonderful, and I won't have the time to do it myself, but I'd want to be sure that the literature is thoroughly searched in this area to see just what actually is going on in this particular neck of the woods in diabetes research and management.
Gavin, let's talk about the research, the level of evidence. There's gossip and concepts through to extraordinarily expensive and extensive randomised controlled trials. Can you walk us quickly through the level of evidence?
Sure. As you say, gossip, this guy has come back from the States and he says it works, and that's great. I mean, if he come back and said it didn't, we wouldn't need to go any further. As you say, at the top end of the evidence pyramid, we have randomised controlled trials. And is there a drug company? Is there a medical devices company behind this? I need pretty early on to know for things that are going to come up a little further downstream. because we cannot run a randomized controlled trial. I'm in an acute hospital. We're so busy looking after our patients with the funds available to us that an RCT is just not feasible and not something I'd think any further about. On the other hand, I would like not just one, but multiple randomized controlled trials to be able to say there is now outstanding evidence that this particular procedure or particular medication, whatever it may be, does in fact work. And that's really what we teach students at the university now. One RCT is fabulous and multiple RCTs with a nice forest plot at the end of all that is what you really need to say, this is it. This really does do what it says it does.
One of the alternatives is that this young surgeon be involved in an international multi-centre randomised controlled trial to develop the evidence. Tell me about some of the issues that you would face as a medical administrator getting involved in a research trial like this.
My first thought is, wow, this is something we haven't ever done before. It could be huge, and, a multi-centre randomised controlled trial is looking a pretty good way to prove or disprove whatever it is we're setting out to look at. Is this one surgeon going to manage this huge thing on his own? This is going to require his head of department's approval to start with at the very beginning, as well as staff. How are patients going to be enrolled? How are patients going to be randomized? How are patients' outcomes going to be measured? So, this sort of trial will involve probably several staff, maybe nursing staff who would be very good at this, as part of the trial in our institution, provided that as we go further and further up the ladder, more and more people give consent to this actually going ahead. This is a big deal. This is not something your average hospital has ever done.
You undertake your initial investigation and you find that there's 2 or 3 reasonably solid randomised controlled trials. They don't seem to be biased, and they do seem to indicate that it's safe and appropriate for some patients. What processes would you want to have in place in your hospital before you considered moving forward?
This really is research. And so at some stage, patients either enrolled in the trial or later downstream, should the procedure become something we actually do at our hospital, are going to have to give consent. Now, consent for a research procedure is different in depth than procedure for a standard, recognised procedure or medication or treatment. There will have to be an ethics committee looking at the sort of consent we are seeking from people for this particular trial. And if it's a multi-centre trial, we probably would be wise to include a local university in this process as well and get their ethics approval. Now, what I've told students in the past is seeking ethics approval delays whatever it is by 6 months. That's how long it takes. And given where ethics actually came from following the trials of Nuremberg, it's appropriate that an ethics committee gives due consideration to the pros and the serious potential cons to this study we want to undertake. So consent wouldn't be easily sought, and an institutional research ethics committee would need to be involved from the beginning, and quite possibly multiple of those if this is a large trial. Big stuff.
So it poses some risks for your organisation. How would you engage the executive or the board of directors, and at what level and what sort of time frame?
If I've got those journal articles you said were looking sort of okay, that's probably the stage at which I would write some sort of business case that's going to go forward to the executive and quite possibly beyond. At this stage, I don't know how many dollars are going to be involved. But on the other hand, if a large international medical device company or drug company is behind this, the funds may not be a challenge. They will be provided and we can go forward. But a business case has to be put forward anyway. And beyond our executive, this is governmental interest as well, for several reasons that I can think of off the top of my head. Firstly, if this is going to work, we'll be famous. If this kills people, we'll be infamous. And so we need to look very carefully at what the implications of this trial might be in our particular institution or jurisdiction or country, whatever that may end up being. So there's risk both to the organisation, which at the moment is, I presume, a pretty good hospital providing a pretty good level of surgery and medicine and care, to something that various people will be keen to say cures diabetes, or, is the miracle cure we've been waiting for. And of course, that in a couple of brief sentences is exactly what the media would love. It's a great story. On the other hand, at the end of the day, I want to be sure that what we deliver is not harmful, probably beneficial, even if it's to a selected group of patients. And so the brief will have to include cautionary notes about media interest and political interest as far as that goes as well. It's a very big issue. I'm going to need help with this. I can't do this by myself. And so if funding is being provided by an external organisation, I want to make sure that there are adequate staffing funds in that as well, to be sure that this is done properly and carefully and safely, because we want the best outcome, which might be this doesn't work and no one is harmed in the process, or this does work for some people, no one is harmed in the process and some people have benefited.
Gavin, you've mentioned the surgeon and the need to collect evidence and reporting to the executive or the board, but there's a number of other people that would be involved throughout the organisation in a trial like this. Would you like to run through some of those and how you would make sure that they were comfortable and on board?
In Australia, at least, the Therapeutic Goods Administration has to be involved early on. Now, presumably what the surgeon plans to implant is a therapeutic good. And so the TGA would need to be involved in intense discussions over this issue very early. I'd also like to know where the tissue comes from. Has consent been sought for this? Is this cadaveric material? Is this from brain dead people who've donated organs? Is this part of, I don't even know what the tissue is, but pancreas presumably? So the ethical dimensions and the practical dimensions of approval from the TGA are essential. In Australia, the Medical Services Advisory Committee might want to get involved early as well, because one of these days someone will be saying this should be provided as part of healthcare, and involving MedSAC early on in that process might be advisable too. But the Therapeutic Goods Administration is critically important, because we can't do stuff to people with products, drugs or devices that is not approved.
Thanks, Gavin. Internal to your organisation, there's also a number of stakeholders. There's the surgeon's peers who may think he's an upstart, or there are other surgeons that will provide support. There's the anaesthetists, there's the nursing staff, both in the theatre and on the ward looking after these patients. They're likely to need to go to ICU afterwards. And then you've got community support and follow-up. How do you get all these different players involved?
A good question. My first answer is this is not the topic for a memo. This is a topic for meetings, huddles, if that's what they're currently being called. But I and others need to meet with a whole lot of people on a recurrent basis to test this out, to see how they think it's going to work, to listen to their concerns, to see, you've mentioned intensive care, for example. How many patients will be going through this procedure, provided it's approved, and et cetera, et cetera? Can ICU cope? Is there special requirement for their management in ICU? So there's detail here that I probably haven't even thought through yet, which is going to have to come from my discussions, our team's discussions with nursing staff, with intensive care staff, with anaesthetists, with biochemistry, with pathology, anyone who is likely to be involved in this. As far as the surgeon himself goes, on the one hand, I'd let him fend for himself. On the other, I think his department head needs to be told that this possibly is one of the great surgeons of the century and needs to be treated with a lot of care, that the head of department needs to ensure that he is supported in his aim and that other surgeons are involved as is appropriate and necessary. That's a job for them in a sense, but I at least want the head of department aware that we've got something very big happening and that this surgeon brought it to us and in some ways is intimately involved.
Accountability for nursing staff, engagement of nursing staff, training of nursing staff is always a challenge, I find, as a medical administrator, because it's really nursing. And you're the medical person, you've got the medical expertise. How do you bridge that divide between nursing body of knowledge and medical body of knowledge, particularly in service development like this?
Look, the beauty of being a medical administrator is that you have had clinical experience. And if you didn't learn early in your medical career about the importance, the critical importance of nursing staff in any and everything that you do, I could, but I won't recount the large number of things I learnt from nurses on the way through, sometimes politely taught and sometimes not. It's my job to have an excellent working relationship, maybe beyond that as well, friendly relationship, but at least a great working relationship with the Director of Nursing. Because without that, I can see this project failing. And it shouldn't, because nurses are part only of this research project, whatever it may end up being, but critically important. And so my relationship with the Director of Nursing has to be excellent and maintained, so that rather than telling nursing staff what I want them to do, the Director of Nursing's got to tell them what they need to do. That's the way that this has to work. It's not really a delegation. In a sense, it's sort of parallel management. I can't and shouldn't manage nursing staff in my hospital, but I sure need the Director of Nursing to do it. I also need her to tell me the problems her nurses are having with my medical staff. This is a two-way street. But the Director of Nursing runs nursing. That's the way it's got to be.
Thanks, Gavin. You mentioned that this is a complex issue. As a medical administrator, who would you likely go out to for advice, either within the organisation or outside the organisation?
I'd certainly be talking to colleagues, and there are plenty of those both within and without the college who I trust to provide me with advice. Given the size of the college nowadays, I'd actually even ask the college, have they got a couple of people they think might be able to help in this proposal? I'd even go to the chief executive and say, I've got this challenge and I'm looking for a couple of people in Australia, in Hong Kong, in New Zealand, I don't know where, who might be able to help me find my way through this process. But, the worst thing I could do is say, I can handle this. I don't really need help or advice. Just leave it to me, because you'll be left way behind and in a terrible mess if you think you can do this by yourself.
You're a Dr. Gavin. You know everything.
I wish.
All right, back to the young surgeon. How do you keep him engaged and motivated? What sort of conversations are you going to have with him to set his expectations about the process and timeframes?
Okay, the two magic words, I guess, are young and surgeon. And the way in which surgeons tend to believe that they are largely independent of all sorts of other things, as I would like them to be when they're in the middle of somebody's chest. It's them and they've got to do what they do and do it well. This young surgeon might need to learn a few things that he hasn't yet learnt about research, for example, and that this isn't a matter of recruiting a couple of his patients and giving them the transplant. Which sounds simple, and with great respect, the young surgeon might think is how this will work. Whether or not it involves international medical companies or whatever, this is a big deal. This is research, this is novel, this is potentially hazardous, even though he may not have seen that in his recent overseas trip. So I can see a fair bit of coffee being consumed between the two of us, because I want to keep him involved and I want to keep him engaged and I want to keep him growing, because this surgeon may end up being a great researcher. After this, he'll find another research project and he'll be far better equipped to do that than he is when he came to me and said, I've just seen this procedure and I think we should start doing it, without understanding all of the other bits, which as a medical administrator, we know only too well. I look after him and I'm going to make sure that the head of surgery looks after him as well, because he'll be buffeted by a whole lot of winds. I mean, imagine being told, it's probably going to take us 6 months to get HREC approval. Nothing takes 6 months in surgery. So he'll need to learn a lot, and I want to help him on that learning path together with the head of surgery.
Gavin, one of the stakeholders I guess we haven't talked about is your insurers. Do you engage with the insurers in a project like this, and do they have the power of veto?
I've actually seen it happen in another environment. It depends who we are as a hospital. Are we part of a larger organisation? Are we a private hospital? Are we part of a jurisdictional health system? In those circumstances, this is going to have to be escalated up if the insurers start making noises like, this is too dangerous, we can't do this, or your policy now is unaffordable. I'm now talking even about politicians getting involved, if that's appropriate, to make sure that the health minister, who must in some way control our insurance processes, understands the process at our end and the risks involved and the measures that we are taking to mitigate that risk. Not just proper consent, but HREC and every other aspect that we can imagine to ensure that the risk to a patient, which is essentially what this is about, although there are other risks that I could talk about, but the risk to the patient is minimised and acceptable because surgery carries with risk. And if our insurers understand that that's where this leads, with research, with all the teams we've talked about being involved, with every precaution that we can imagine being taken, then quite possibly the insurers will say, this is okay, you can go and do it. But they're very important players, as you say, and I'd hate this project to be stopped on the say-so of an accountant somewhere. That would be most unfortunate. So I'd escalate this as far as it needs to go to ensure that the insurers stay on board, given that their knowledge of what we are doing is adequate for them to understand that the risks have been taken care of to the best of our ability.
Absolutely. The other stakeholder that you mentioned just now is the ministry or the department or your funder. It can be quite beneficial to a research project if the department is on board and effectively sets you up as a state or national pilot site. What are some of the positives or negatives of moving up to a state or national pilot site status?
Look, the positives are the sort of glory which comes with it. I mean, imagine our hospital, which until now has been really good, suddenly becomes the state, the jurisdictional, the national site for diabetes cure, if it ends up going that far. Just imagine. But on the other hand, it may fail. We need to be sure that those in power above us haven't come to cut the ribbon on the Diabetes Cure Centre before we have had an adequate and probably long time of a research project to be sure that it does seem, in some people, whom we can now learn to select better, does reduce their need for insulin or cure their diabetes or however far this may end up going. But it's not something you just jump into, and that's why my team is going to be critically important to make sure that I don't get carried away with the minister cutting a ribbon. I want to be sure that we are delivering safely best practice surgery, medicine associated with this in a research context, hopefully funded by others. And that, at the end of the day, it will be what it will be. And we will know that because hopefully, as you suggested before, we might even be part of a major international study. And the likelihood of that giving the answer, the right answer, is high. And being part of that would be a fabulous thing to do, whatever the end answer might be.
I'd like to come back to the issue of engagement with the media. There's two extremes. One, you could go out proactively and tell them what a great hospital you are because you're going to do this. On the other extreme, you could take the nothing of interest here, go away. It's a judgment call for many of us as medical administrators to make. Where would you sit in the engagement with the media? What are the risks and what are the benefits?
First, I think either you or your media team have to be media savvy and know what the media wants. The media wants stories, and they can be good stories or bad stories. But there's nothing here, we're just doing a bit of surgery, go away and come back later. That's not a story. So if, as I have in the past, had great media contacts, we can work together to produce something that is going to be quite beneficial about a research study currently underway. The worst thing, of course, would be cure for diabetes just around the corner at Hospital X. No one said that. And the other important thing, I guess, for younger medical administrators is if you don't say it, they can't quote it. So be very careful of what you do say when you are talking to the media, and media training is an excellent thing to undergo. I recommend that people should do that. If you've got a media team, this is where you go first, and you work with them to work out how, to whom you will give what information at what part of this major research project. There could be a story that the hospital's involved in a major research project looking at ways of better treating diabetes. Not much of a story, likely to go away. On the other hand, if you say, we've got a surgeon here who believes his transplants will cure diabetes, you'll have television crews looking for what really is going on, invading your wards, talking to people they possibly shouldn't be talking to about things they shouldn't be talking about, and a nightmare. And once that genie is out of the box, it's extraordinarily difficult to control. So you and your media team, if there isn't one in your hospital, your organisational media team need, and the chief executive's briefed, and you've briefed all the way up, of course, on the way, but they need to manage this process if they're at all good, and most of them generally are. It's a process that's their line of business, not necessarily your line of business. So let the experts deal with this as you would let surgeons deal with surgery.
Thank you, Gavin. A very challenging scenario, one with great potential, but also great risk. And that brings us to the end of this episode of Safeguarding Healthcare, where I was in discussion with Professor Gavin Frost, former Dean of Medicine at the University of Notre Dame, Australia, Chief Medical Officer at NBF, and former CEO of the Royal North Shore Hospital. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.